Now that you've heard about the call to action, about the clinical services review itself, and also about the emerging case for change, we wanted to give you another opportunity to peruse that data and to have a look at that in some detail. We'd like to bring you back to your chairs, give you the opportunity for you to tell us your observations of what you've seen and to ask us any questions that you have.
We've got all these projected what we're going to do, and we haven't really got the money to spend it, and how are we going to save it? And I'd like to suggest, because I was chair of a scrutiny committee on a council, and the number of bariatric surgeries that we do is phenomenal. And some people are having 2 and at least 3. They get to a stage where they lose weight, they think they're great, they have another one, and so it goes on. And so I think more could be done. I thought that the NHS was formed for people with serious illnesses, and I do think there's a stage when people have got to look after themselves. Thank you. I'd like to hear what you'd say about that.
Okay, I mean, I think the purpose of the review itself is sort of quite high level, really. So in terms of getting into the nitty-gritty of very specific specialities will be quite difficult within the review itself. So we're looking at general principles, but certainly in those areas where we have things where we think it's not best value for money, then certainly we'll be considering those. Got a lady there.
Just like to pick up on the bariatric surgery. I've had bariatric surgery. The only reason I accepted that was because I couldn't get any psychological therapy. So, you know, if there was more help earlier on, people wouldn't get to that stage. I think one of the ways forward is to actually invest in some people with lived experiences of alcohol addiction, drug addiction, and mental health problems, actually going into schools and talking to people. I was involved recently in a project funded by Time to Change called Tea and Talk, and we picked up a lot of distress in school children in the process of that. So I think, you know, by having some people who've been there, tried that, and found it wanting, might turn some of these young people's lives around before they get to the stage of any kind of addictions.
Okay, thank you. Anybody else want to comment or ask a question? Who's next? I've got our arm down here. I'll come to you after that.
I had my first free NHS health check this morning, being in the age group between 40 and 75, and I'm told that my risk of cardiovascular disease or whatever is 7%, and I need to get more exercise and drink less and lose some weight. It strikes me that more emphasis and concentration on that sort of thing would increase your avoidable admissions and reduce your costs.
I think there will be more of a focus on prevention, and as you say, there are a lot of issues, health issues, which are down to people's own personal choices in life, and that's something that we do need to target in terms of education. I've got a gentleman at the back there.
Yes, my question is, my experience is not as a doctor, of course, or a physician, but simply because I deal with a particular area of men's health. In the last 14 months, I've spoken to 1,500 men personally, and I run a helpline, a national one and a local one, and I've spoken to about 500 men on that. So I actually speak to the man in the street, a man who probably wouldn't go to his GP, who has problems and is prepared to discuss it on the telephone, initially anonymously, and then perhaps on a second or third time he would speak more deeply about his problems. So my question is, the big ask, how do you know you're reaching the whole population? Because I don't think you are, and I think the people who have some of the most difficult problems facing them cannot put into terms which would be perhaps acceptable or understandable by his GP. And so he's reluctant to go to a GP and discuss it with him. And there are some GPs, not most GPs, but some GPs who actually don't have a very good bedside manner and who are not prepared to actually listen and to get from a man exactly what his problem is. And that's one side of it. And so I think if you're going to say this is your vision, your voice in your NHS, it has to be you, and that's every part of society. That's my first point. My second point is this, and it's the more practical one. If you want to cut down the amount of expenditure, and this has gone on for years and years, why is it that so many patients get away with not turning up to their appointments? And there ought to be a system. I know it's difficult to find them, but certainly I think you could run a system whereby you say to any patient who's given an appointment, will you please ring us a week before or 3 days before, however long, to let us know that you are going to attend your appointment. Otherwise, we will offer it to someone else. Put the responsibility for people's health back onto the people and not the NHS have to do it for them.
Okay. There was an issue around how to reach the hard-to-reach people, so I'm going to hand over to Francis to hopefully answer that one for you.
Thank you very much. Just a couple of things, really. When I heard you talking, I'd like to extend an invitation to you and your 1,500 members to join our health involvement network so that we can absolutely keep you informed and have those conversations. You're absolutely right. The challenge of talking to the working well, the people who aren't here tonight, is an ongoing issue, and we want to do as much as we can to reach out to those people. One of the reasons we're filming tonight, as Phil touched upon, was so that we can actually stream that through various channels, send it out widely through all of our different networks, working with Health Watch, our councils for voluntary services, our minority ethnic groupings and so forth, so that we can give as wide an opportunity for information, involvement, participation as possible. It is an ongoing challenge. In terms of the big ask, that was actually done for us by Bournemouth University. It was sent out to 20,000 people. We had 6,000 responses, which was pleasing. But they have the demographic data for us, and it is actually quite pleasing spread across our demography, geography, and diversity. But we have that data if you're interested. But thank you for your comments, and you're absolutely right. It's an ongoing challenge, and one which we're hoping, with help from people like yourselves, we can actually move in the right direction. So thank you.
Coming back to patients who don't attend for their appointments, I think, first of all, you're right, it's a big problem for all of us in healthcare. I think, first of all, though, I would suggest you need to understand why that is, and there are certain groups who will forget, people with dementia, for instance, some people who live in chaotic lifestyles, who live maybe in an area I look after, which is Boscombe. Some are cultural issues, so I think we need to recognise that there are reasons why some people do not attend, but so we need to work with them to find out why that is. The other thing I think is that another way to deal with this is actually, and it happens in some practices, is to contact patients using social media and remind them that they've got the appointment. That's been shown to cut down non-attenders. But you're right, it's a problem we need to deal with.
Okay, question here.
I'm a community pharmacist, and I've already spoken to Phil. We get more working well people in community pharmacy that are open till 11 o'clock at night, one of them here, 7 o'clock in the morning, can be accessed by all those men on their way to work. If you've got a public health agenda, that's where you should be looking at community pharmacy. And also, I would like to comment on the 111 service. You need to have a big publicity drive, because in my experience, many of the general public do not know about the 111 service, or do not understand it, or even know how to use it. Another, for instance, patients who don't have their medication can obtain that through pharmacies, but at the moment, at out of hours, but that is for a payment, even if they'd normally get it free, so that is a problem. The 111 service itself, I know they have to go from a script, but I have had personal experience and talked to many patients For instance, we had a man, 90-year-old, collapse at church. We didn't know much about him, except he wasn't breathing very well. And the 111 service were insistent they would not send an ambulance until they could talk to him. My husband spent 10 minutes getting us an ambulance eventually. All we knew was he was in pain and his breathing wasn't good. So I think really, really look at the 111 service, please.
Okay, I mean, certainly feedback about individual cases, if you haven't, it might be worth feeding that back, if you haven't, to the 111 service, so that they can look into that to review that particular example. In terms of patients, how well they would know about the 111 service, all I can say is that every GP practice is mandated that when they're shut, that their answer phone actually gives the 111 number. So anybody phoning their practice out of hours will get through to an answer phone which tells them what number to phone. I agree, though, that we could do more in terms of educating people in terms of phoning 111 if they don't phone their practice and get that number.
Yeah. I think the other side of the story is I heard from a GP in Blandford last week where 111 had been called and the patient actually needed emergency care, and within 10 minutes an ambulance was then called and they did get that. So I think there are clearly stories for both, for all the spectrum of responses. What we've seen looking at some of the data is that 111 has much more use than what was NHS Direct, with a number that was actually too long to remember and therefore dial. So we're seeing a massive increase in the 111 data. So the ambulance service who runs 111 on behalf of us in Dorset are constantly reviewing their performance, how they're operating, some of the individual cases. They're looking at all of those things with a view to improving the service they offer. But I completely agree with you. There is a big education piece to do, and we're certainly part of how we can help educate that. And as Simon said, the surgeries have that, but it doesn't cover the people who are right up until the point they need to dial something. It doesn't cover that group who were well up until that point. So I think, but I really do. As you and I talked about the pharmacy piece earlier on, I think there's, the bigger footprints that we can get the messages out on, the better. So I think that's absolutely the way to go.
Oh, sorry, I was just going to add actually that pharmacies are an important part of how we look after patients, and we have tried to commission services from pharmacies in the past, and I thought that Health Check, which actually isn't part of the NHS side now, local authorities have the budget for that. I thought they'd put out contracts in pharmacies to do the health checks there. Sorry, mine done at the community pharmacies. Yeah, so it's already being done, but yeah, we must involve pharmacies within the health economy. I work in dementia, and I know that we ran a pilot where pharmacies will identify people with dementia and help them manage their medicines better. So yes, you're right.
Okay, I've got several people with hands up. I've got one down the front here, second over there. There's a lady and then a gentleman over here. So that's 4. No, I've got this gentleman here to start with. Sorry, down here.
Thank you very much. I live in North Dorset. The bloods that I give are sent to Dorchester. My heart is looked after by Bournemouth, and my cancers are looked after by Poole. And unfortunately, Dorchester's computer system doesn't talk to Bournemouth or Poole. So I'd like you to, as doctors, stand up and shout, we'd like the government, whoever it may be, to instigate a Tesco-style computer system. Because if I spend my credit card in Edinburgh, Tesco's knows what I've spent.
Yeah.
So you should be able to have a system somewhere.
I can assure you your frustrations are shared between all clinicians. Ideally, we would like every person to have the same clinical system so that all clinical systems talk to each other. The major stumbling block is the thing about choice, and that people do have choice to have different clinical systems, but that's certainly something that we will be looking to work towards, an integrated IT system. I had a gentleman over here and then the lady over there.
Hi.
On all the boards, I've not seen anything at all about chronic rare diseases and the position they hold, because from my experience in Dorset, particularly for neuro conditions, it's not as good as it could be. And I'd like to think that the rare diseases would be put somewhere into the overall plan.
I think in terms of looking at things on a high level, that then the plan is looking to include spectrum of disease, including those at rare diseases. So what we're looking at is what would look good, not for just rare diseases, but other things as well. So you would be able to say, well, this is what works well for that, and you can extrapolate and necessarily say, well, okay, that will look good for that. But then you may need to think, well, okay, well, we'd need to tweak it to deal with those particular things. But yes, we're certainly looking at considering those as part of the whole picture. Okay, there's a lady over here.
Thank you. You've been talking about how the NHS, how the CCG can do it better. If we flip it over and say, how can we help the patient to do it better? And I don't mean by that public health, change of diet and that sort of thing. I mean, how can we help the patient to get the best out of the treatment and care services that you offer? And I have a vested interest. I work for a voluntary organisation providing cancer advocacy support, and I think it would be a good investment to support those people who are at risk of being overwhelmed by their health issues, to be supported in navigating what's on offer to them from you, and that voluntary sector services are very good value, and we can leverage an enormous amount of support from skilled and motivated peer volunteers in the community.
Yeah, again, you're pushing against an open door here in that I think we would all recognise the voluntary sector as a currently sort of underutilised sector out there, which we should be able to make more use of. I've got a lady with black on the end there, and the gentleman in white with stripes, second.
Hello. Yeah. Concerning things like diabetes and those sort of diseases, wouldn't it be good if you could liaise with the education department and from children, from when they're young, what best foods they have, how it affects the food they eat, etc., etc.
Yeah. Yeah. Okay. Gentleman back here.
Thank you. It's basically a follow-on on that particular question. And obviously here tonight we've got a lot of older people. How do you consult with the children and young people, maybe the future generations, and how you process that? Because young people will not come to a place like this sort of thing, but how you will do that within youth clubs, schools, etc., etc.
Yeah, I've got 2 teenagers myself, so I know the exact problems that you're talking about. I'll hand over to France again, actually, to answer this one.
Thank you. Very good point, and something that's very high up our agenda. Since we started the process, I've looked at how we can better engage with and give more opportunity to, and importantly, information to our younger population. Just last Thursday, I was presenting to Dorset Youth Council and exploring with them how we can actually get information out to the young people of Dorset about what we're doing and why. And they're actually going to help me co-design a poster and possibly some video clips as well, which are their ideas. In addition to that, I've been speaking to the 0 to 19 forum, so the voluntary sector organisations who work with young people, linked into Dorset Youth Association, and we have a young patient leader on our patient and public engagement group who's actually working with the British Youth Council. We're also looking at holding a number of forums in the spring with young people across different vulnerabilities, geography, diversity, demography, across the county, so that they can help us think about how we can design the consultation phase with them so that they can have a true and strong voice. So thank you for raising that. It's very important.
I'm aware of the time. I've got time for a couple more. So I've got one down here.
I have a question for Mr. Richardson. I applaud the initiative that's driving this clinical services review. I assume you have a budget for your activities for this great project?
Yes, we do.
May I ask what it is?
Yes, you can. We have allocated £2.75 million to run the programme.
Is that inclusive of all the consultancies, etc.?
Yes, it does, yeah.
Thank you.
Mine's quite a high-level question. You have an awful lot of work to do, a lot of people to talk to. I am very concerned that you're trying to tie this all up by the end of 2015. I really do feel that 2015, to do all this work and to get it right, is not enough time. There is an old saying, much haste, less speed, and I fear very much this idea of let's get it done now, which is a sexy thing to do, may well be your downfall if you really go along that path.
Thank you. That's a great question. We've taken advice from NHS England, who've tried to make changes in the NHS over many years. And what they've found was that if you leave it too long, it ends up not being changed. So you end up with a lot of management consultancy reports on the shelf with no real change. If you do it too quickly, you're absolutely right, you end up with probably breaking the very thing that you're trying to fix. So what we've done is we've taken a balance between putting enough pace in it to getting to the top level picture that we need. So this is the whole thing not implemented. This is getting to the top level picture, and then following on from the consultation, the decision in the autumn, that's when we start to drill down into the very specifics about what the services look like, what the clinic structures will be, what the hours of GPs will look like. All of those things follow that point. So the actual work continues forward. What we've also pushing up against is the 167 million deficit number. So if we take a year, then we already know it's going to be 167 million. And if we take 2 years, we then know it's going to be 350 million. So we're trying to balance between good advice from good experience about doing things at pace, balancing about the investment and the economy that we're trying to work towards, and getting to a top-level picture that we can then take some considered time about engineering, if you like, some of the detail that sits underneath it. So that's the decision we've taken. Whilst it feels quick, and if you were working with the team in Vespasian House in Dorchester, they all feel it's really quick. And we're also engaging all of the GPs who up until this point haven't had to work at this pace with this kind of topic, so that's all very quick. But what we found is we started essentially in the beginning of October, and this week, the week just gone, we had a first for Dorset, which is we had all the chief execs, all the council leads, all the chairs of all of the boards, and all of the chief execs of the local authorities all in the room saying, we need to do this for Dorset. And I think if we'd said, some point in the next 12 months, we're going to try and get everybody together in a meeting, I think it's one of the benefits of doing it at pace. People just change their diary. So we had a first the week before that, which is 106 clinicians in a room from Bournemouth, Dorset, Dorchester, Poole. We had 50 GPs, roughly 50 GPs in the room, nurse practitioners. We had the ambulance service there in uniform in case they needed to do something. We had all of that happen. And I think it's the pace that's helping us really generate that effort. So I think it's a balance between the advice we've taken from NHS England, who oversee all of England's NHS, the funding that we know we're heading towards this funding issue, and what you can generate with pace just in terms of getting people galvanised into action. So that's a blend of all those things, which is why we've ended up where we are today.
Okay, I'm going to have to draw it to an end there, I'm afraid. Thank you for all your questions. I've just got a couple more slides quickly to show you. We'd like to keep you to carry on being involved, because really this is just the start of the process, so we need you to keep coming along. So in January, with the next sort of phases, we've got 3 more events coming up, so if you can put those in your diaries. We'll email them out anyway. I'm going to everybody got those? Yeah. So this isn't the only way to get involved. Okay, so if you want to sign up to our Health Involvement Network, again, ask the staff at the back, they'll take your details if you haven't already. You can see what the sort of forthcoming data that's going to come out and what we'll be looking to do in early 2015. And importantly, here is the website that you can go to, the phone number you can ring, or the email address. But as I said, you can actually ask at the back now if you like, and to get those details. Just a very big thank you, really, to you all for coming this evening. I'm quite impressed with the number of people that we've got here. But as was said earlier on, next time, please bring your friends. The more the merrier, okay? We do generally want your input into this. We don't know what the answer is. We want your help in steering what that answer is, and we can't do that without you. So the more of you that can come, the better. Thank you very much.